Welcome to the Sustainable Clinical Medicine podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Before we get started, I just wanted to remind those of you who are working on backlogs, just check in the www.chartingcoach.ca/backlog-buddies is the place you can come and do your backlog alongside fellow clinicians and physicians. So if you want to kind of hang out and have some ability to stay on task for the 2-hour sessions, come along. We'd love to see you there. Hello and welcome back, everybody. I'm really excited to share with you this guest today. Marc-David Munk is a physician and an author. I'm going to let you introduce yourself. We're so excited to have you. Welcome.
Sarah, thank you so much. It's just a pleasure to be here with you today. So I'm a emergency physician, trained a number of years ago, Canadian originally, ended up in the US, have practiced in the US much of my career. And I'm on your podcast. I mean, I started my career in academic emergency medicine and quickly hit a wall and needed an opportunity to pivot. And so would love to discuss the pivot with you today. I think that's probably the key topic.
Perfect. Let's start with the wall first before we go to the pivot.
Sure.
So tell us the how did that all come about? So you're working, you're in the emergency department. It's not even COVID, clearly, because this was a number of years ago. So tell us what was happening that wasn't so good.
It's kind of a funny story. Let me take you back a couple of years. I started off as a college student studying the humanities. I graduated university with a degree, believe it or not, in philosophy and religion. And I would have never expected to have ended up in a career in medicine. It was nothing that was on my radar when I was a young man. But I had the good fortune to go to school in upstate New York, and there happened to be a volunteer ambulance service in that small village. And so they recruited students. In some cases, they recruited townspeople to serve as emergency technicians on the ambulance. And I signed up. I thought it was an interesting thing to do. And of course, one thing led to the next. And there were a couple of fascinating cases. And I spent most of my time in university in the barn, training and going on emergency calls. And by the time I was ready to finish university, I realized that I really should head in the direction of medicine, and had to go back and for a couple of years take the basic sciences from scratch. And the long story is I ended up in medical school years after people in my class. It took a long time to get there. And as I described briefly in the book that I wrote, it was a series of sort of incremental developments, medical school, and then there was residency, and then I did a fellowship. And you finally jump through all of these hoops in training. And I was, one day a newly blessed attending emergency physician working in the university hospital. And that was that was terrific for a couple of months. And then I looked around the emergency department one day. I came in for a morning shift, and I looked around the ER and I realized that the place was on fire. I mean, but I realized it was on fire every day. There was no quiet time in the emergency department. And I felt this sinking feeling when I started going into for shifts that I knew what the day was going to bring. And it was going to bring stacks of patients in the waiting room going out the door. It was going to be crises that we were trying to pick up in the waiting room that we sometimes missed. It was going to be corner cutting and shortchanging patients because there just wasn't time to deliver the type of care that I felt should be delivered. And so I started to get this sort of sinking feeling that all of the things that I had gone into medicine to do, which was to spend time with patients, to form relationships with people, to get to know them, to escort them and treat them, everything that I wanted to emulate from my professors in medical school suddenly seemed unachievable. There was just kind of this industrial assembly line of medicine And there was nothing you could do because, of course, if you wanted to practice like that, people would die. It was just your hair was on fire all the time. And I realized quite quickly that I was disappointed, right? This wasn't what I had imagined that it was going to be. And I realized that I needed to take some time off. I had the good fortune when I finished my fellowship, actually even during my fellowship, to work abroad. I had done a fellowship in global health, international medicine. And I realized that there was something really profound about practicing overseas, that it to some extent got you out of your comfort zone and forced you to start looking inward and asking hard questions of yourself. And I realized I wanted that experience as I was taking my new work in emergency medicine. And fortuitously, I ended up cold calling an organization in Africa called the Amref Flying Doctor Service. And I said, "Are you guys looking for a doctor?" And they wrote back within 24 hours and said, "Absolutely. Are you free in a couple of months?" And I said, "This is a sign." And so I signed up right then, and I was on my way to Africa soon after.
That's funny. It's I'm sure that if you'd rung them at any moment, they would have wanted you, because I don't think that there's always a lot of doctors to do different roles. But for you, it was like a sign.
Yeah, this is a sign. I mean, this is destiny.
They clearly need someone, so that must be me.
Yeah, I could be. I mean, I think they're a pretty popular organization, and so
Yeah.
I was lucky that they just happened to have an opening, honestly.
Okay.
But yeah.
Ooh, that's good. That's good. I understand this identity crisis that was going on for you, and you're like, this isn't what I signed up for. However, this wasn't your first emergency department as an attending. Like, you'd done a fellowship in it, you'd been in the emergency department for years at that point. And suddenly the on fire was the experience, and the disappointment was the experience. I'm just so curious, why do you think it was the number of years you'd been in that position? Was it it had just got you down? What do you think? Was it not sleeping well? How did it all kind of come to a crisis then?
I think that we physicians have this remarkable ability to rationalize unpleasant circumstances, and we tolerate a lot of dysfunctional systems in the name of professionalism, I think. And we could talk a little bit more, I think, in this podcast about how broken the American system is in particular. Although, the Canadian system is broken, the English system is, I mean, but they're suffering from different dysfunctions. In America, the dysfunction is primarily driven, to my mind, by greed and by a broken remuneration system, the way that we bill and pay for service. But to my mind, the people who've organized the system deliberately tolerate these dysfunctional systems because they know full well that the physicians, in the name of professionalism and ethics, will step up and do whatever it takes to keep the wheels on. We will never let a patient get sick or deteriorate, or so we will skip our lunches. And we will not go to the bathroom for hours. And we will simultaneously be on phone on two hands and managing a chart and handling that kind of stuff. And I think we rationalized it by saying that's just the way it is, or this is just kind of a busy time, or, we keep coming up with excuses as to why the situation looks the way it does. I think not wanting to recognize the fact that we're actually quite powerless. I mean, it's at the end of the day, the system is so much designed and driven by others, administrators, politicians, bureaucrats, insurance companies, that we, I think, very much like sort of abused spouses, tolerate this dysfunctional situation, sort of crossing our fingers that the situation will somehow improve over time, and if we just bide our time, it will get better. But of course, anyone who's lived with a abusive spouse knows full well that it never does get better unless you put your foot down. And maybe for me, I mean, I'm sort of in this podcast, a little bit ashamed to have this conversation because I was relatively young and relatively fresh out of training when I had that realization. And there are so many of my colleagues who've put up with this for 20 years, longer, and just go in and grind it out and do the work that needs to be done because patients need to be seen. And so I worry sometimes about being thought of as a bit of a whiner and somebody who broke earlier than many. But that was my story, and I needed space to really think about what was next.
Yeah. Did you have anyone, as you were doing residency or within that new attending or within your circle of friends, who was kind of watching out for you and noticing that you were coming in with this dread and this disappointment, and you're like focusing on this it's this crisis, we're understaffed, this isn't going to get better. Why does it have to be like this all the time? What was happening there when you would like talk or vent or?
I had wonderful mentors.
Mm-hmm.
I trained at the University of Pittsburgh, and I was, it's just wonderful, wonderful people with a strong focus on pre-hospital medicine, which was my area of interest. And so, but I think we were all in the frying pan, to be honest with you. And I think that there is a certain degree of machismo, I think, in medicine, particularly emergency medicine, where you just do what's necessary to get it done, and then you'll go out for beer afterwards, and you'll commiserate and sort of joke about good cases and bad cases as a way of providing consolidation to one another. But of course, then you go back in and do it the next day, and it's just kind of what we've learned to do.
Mm-hmm. Yeah. The emergency department, I guess, over because I've seen it in Australia, I've seen it in Canada, I've seen it kind of in that during and then post COVID, and it might have been possible before when you would come on shift, you try and leave an empty waiting room for the next crew, right? You'd be kind of like, let's get in there. And it's interesting how, you've got these people who are in there for 20 years and they're thriving, or they appear to be thriving. And maybe if we poke them a little bit, maybe they're not thriving, and maybe that's something to reflect on as well. But it's kind of interesting that with the volume coming in now, it's just not a possibility. And that mind shift to say, yes, it's busy, and we're not just not going to get to that empty waiting room for the next crew by the end of this shift. And that's just our way. This is just that number of people, the busyness of the departments, the like you said, we deal with this chaos. We just do it because we want the patients looked after. I know when I turned up in Tamworth, Australia as an intern, we had a 5-bed emergency department for 100,000 people, and we would see people in corridors, in waiting rooms. We kind of pull them in for their physical exam and pull them out again, so we can pull the next person in for their physical exam and out again. It was just chaos until they built this brand new, big, nice, beautiful department while I was still there. It's kind of interesting, the emergency to medicine collegiality. I think you're right, that going for beers after work or whatever that looks like for your team creates some degree of community amongst the chaos of crisis, but not necessarily the intimacy of knowing that this person's not thriving well here.
I think that's right. I think what happened over the years is the emergency department really is the barometer for how well the system is functioning in aggregate. So if you, for example, have a problem with not having enough rehabilitation beds or skilled nursing beds, that cascades obviously to the inpatient setting, which then cascades obviously to the emergency department. And the only place that there's a constant open door is the emergency department. There's no way to control the flow in. And so no matter how congested the output is, the input keeps coming in and keeps coming in. And I think that's really, I mean, the other thing that's happened certainly in the US is that there's been over the years investment in things that generate revenue. And so centers of excellence in cardiology, centers of excellence in oncology, centers of excellence for well-insured people, those things keep getting built. But at the same time, the emergency department is a loss leader for many people. And it's there because it's necessary. It's for running a hospital, but nobody's all that interested, frankly, in putting money into it or building a highly functional system. And so we're sort of squeezed. And I think, the obvious question is, did you pick the wrong specialty? And that's entirely possible. I mean, maybe there are, as you say, people who thrive on this. I think they're a certain type of person, but I don't think any of us, if you ask them really, I think most of us would like to practice in a way that's thoughtful and sort of slow down and then speed up, and then take time to sit with a patient for 20 or 30 minutes to really get to the bottom of something complicated, but then pivot and do a couple rapid UTIs. I mean, that's fine, but it felt to me that it was this constant nonstop corner cutting, which was to me the real problem, where I'd love to do this workup, but I can't. I'm just going to call the internist because I just can't. I can't deal with this right now. There's too much going on.
Yeah. You found it unsustainable, and that is absolutely like your personal journey here was, this is not for me. This is not a place I'm going to stay. I'm going to look for something different. And so you did. So tell us about the pivot then. We're going to let you get.
So Africa was a very interesting place. I specifically chose this gig, because I was always interested in tropical medicine and
Mhm.
infectious disease. I'd spent time in my fellowship doing it and had been certified in tropical medicine, and loved my time in the Middle East, where I worked for a couple of years as well. So there was something kind of fascinating about working in these international settings where you've got the cultural issues to deal with, you've got the language issues to deal with, you've got the different types of medicine, and you don't have the pressures of the industrialized healthcare system. And so it was a very, very nice place to practice medicine. And I knew it would provide a refuge for me to create the space to look within myself. And I think the question I was trying to answer was, are you living the life that you ought to be living?
Mhm.
Are you in the right space for you?
Mhm.
And that was the question that I really tried to answer. And as I wrote in my book afterwards, I really extensively quote two people. One is Joseph Campbell. Younger listeners of your podcast may not know who this guy is, because he was big in the 80s and 90s, but he was a writer and theologian and thinker who really wrote about creating this sacred space to listen to yourself.
Mhm.
And he talks a lot about the journeys that people take outside of their daily lives to answer this question. And the other person I quote is a fellow called Dag Hammarskjöld, who was the second Secretary General of the UN, who also was on a very interesting journey of self-discovery when he was first creating the UN and doing peacekeeping missions in the 60s in Africa. He was killed, by the way, in a tragic plane crash in Africa, kind of under suspicious circumstances.
Mhm.
But that's a different story. So, so I found myself in Africa asking myself these questions. And the book that I wrote, Urgent Calls from Distant Places, is really a discussion or sort of a series of short essays of 22 missions that we took across 11 countries in East Africa caring for patients. And it's kind of funny because I wrote the book in 2024. The stories I'm recounting, as you say, are stories from 2008 and 2012. And people always ask me, like, why are you, why did you bother writing these stories in 2024? What relevance does it have for you today? And the short answer is, I mean, I had the stories on my computer and I thought that they were fun stories to share,
Mhm.
and in some cases, touching stories and meaningful stories. But in retrospect, as Steve Jobs sometimes says, your life doesn't make a lot of sense looking forward. But when you look backwards, the dots connect in very interesting ways. He was
Mhm.
writing that, he discussed that in his commencement speech at Stanford University several years ago. And I realized that for me, that time in Africa was this pivotal moment in my career where I made the decision to pivot from full-time clinical practice, and commit to actually trying to get a bit upstream to fix the system. And you would chat a little bit more kind of how that ended up, but I ended up going back to school to get skills in finance and management and operations, because I realized that without those skills, we were at the mercy of the powers that be.
Mhm. Yeah. Okay, where did that take you? Because that's kind of interesting that you kind of went upstream to say, how can I fix this?
Mm.
Tell us more.
I knew that I wanted to try to fix the system, and I had this realization that there were a couple ways to try to do this. I mean, one was to work within the system, and a lot of people have decided to do this. You get a manager job or a medical director job within the university or the organization you're in, and people do terrific work there. I mean, they
Mhm.
incrementally make improvements
Mhm.
the day-to-day life of clinicians. And the best chief medical officers, and I became a chief medical officer for many years after this, but the best CMOs to my mind are the ones that create buffers for their physicians to be able to do what they want to do. That's, to
Mhm.
me, is the definition of an effective clinician administrator, is that you create that space and you minimize the interruptions and you minimize the pain for your doctors. That's the sole purpose of the CMO, if they're doing it right, which is an open question. So I realized that there was two ways to do it. One is to get in the system and try to fix the system from within, very admirable. The other is to be an outsider and actually try to create disruptive models that are proof of concept and sort of show a better way of doing things. And I
Mhm.
chose the latter. I've spent the past 12 years of my career working for disruptive healthcare organizations here in the US that are, for example, doing primary care in a completely different, highly intense model of primary care delivery in lower income communities across the US. I worked for a little bit of time in retail medicine, which in short is trying to provide broad access to people in pharmacies, for when they have low acuity conditions and don't have an appointment and need to be seen for something. To me, that was a very interesting way of providing low acuity care and decompressing the system a bit. What I've been most interested in are alternative ways of paying for healthcare, because I'm fully convinced that the way that we reimburse healthcare, actually in Canada and the US, is this fee for service model, which is breaking everything. It's completely the wrong way to pay for healthcare. And so that was my pivot. My pivot was into administration and trying to build these disruptive systems. And if we were correct and they were better, the market would respond.
Interesting. What does a disruptive primary care clinic look like?
So this is I love this story. So I got a job working for this remarkable man who's a mentor and a friend and an inspiration, a fellow called Rashika Fernandapule. He was an internist who worked for a while at Mass General Hospital and decided to set out on his own and create much higher touch primary care models. He originally did them in partnership with unions. He did them for the casino workers in Atlantic City, caring for their employees. He opened clinics caring for Zappos. Remember the Zappos shoe company? And provided clinics for them. And the idea was that it was going to increase access to great primary care. And when I joined his company, the organization had pivoted into providing care for seniors. And we opened, over a period of just a couple of years, dozens and dozens of these clinics that were located in lower income neighborhoods across the United States, Phoenix and Denver and Seattle and Boston. But the idea was that the clinics would be located in strip malls next to Walmarts mostly. So that was the demographic we were going after. And the reason it worked is because we had arranged to get paid differently by the insurance companies and the federal governments. They were paying us now on a per member per month basis, which gave us enough money actually to provide very, very robust high touch primary care. So picture appointments that were 30 to 45 minutes in length routinely. Picture health coaches assigned to every patient to keep track of the panels. Picture nutritionists taking our members to go shopping for groceries so they could understand which foods they should be eating and not eating. Picture the money to buy, for example, there was a woman who was missing, Rashika tells the story regularly, a woman who was missing her dialysis appointments. And we asked, why are you missing your appointments? And she says, I'm so bored. And so we had the money to buy her at that time an iPod and loaded it with her favorite music. And she never missed another appointment. She would sat there listening to podcasts and stories and music. And her health was transformed for, what did an iPod cost back then? $150 or something. But we just didn't have the flexibility in the system to be able to make those kinds of investments. And here we did. We had enough money to do that. So the model was very successful. Did great care for seniors. And it was ultimately bought by a company called One Medical, and then was purchased by Amazon, believe it or not. And they're now providing primary care. So interesting story.
Yeah, absolutely. Very fascinating. Okay. With the burnout and with those people who may be within that like emergency department model, or maybe even the primary care model now, that fee-for-service model, if they've got that burnout, what are some of the things that you've learned that might be helpful to them?
I think it's my own journey was getting back to a very primal version of the doctor-patient relationship, which was reminding myself of why I got into this business and reminding myself of the importance of that relationship with somebody and accompanying them on that journey. I quote at the beginning of my book, Paul Thoreau, the great travel writer, and his quote it's just the very first few pages of the book is, I sought trains and I found passengers. And I think what Paul was trying to say is that sometimes we go in looking for very big, complicated systems in the Big Bang Theory. And at the end of the day, it's actually not about the Big Bang. It's actually about people that you find in the stories that they share that provides meaning and purpose. And again, when I got out of full-time clinical practice in emergency medicine, I would remind myself, even in an administrative role, to go and see patients, even in the primary care clinics. I'm not a primary care doctor, but I was able to do same-day visits for for seniors. And to me, to spend that time in the clinic and see these patients and get to know them a little bit and hear their stories, and it reaffirmed for me the reason why I was in medicine, that decompression was very important for me. And it was something I think I learned in Africa, spending hours on a medevac flight of we the stories of going to Ethiopia and northern Kenya and picking up these patients and spending hours on a flight with them. People from completely different backgrounds. I mean, we don't share the same language, we don't share the same religion, we don't share the same culture. Completely different socioeconomic backgrounds. Their lives, I mean, I couldn't, but yet we could quickly form that relationship. There was a universality, I think, to the doctor-patient relationship that people immediately recognized that I was there to help. And to me, that was the touchstone. And if I could keep that in mind, like clinical administration is not always fun. But clinical medicine is not always fun either.
Yeah.
And there are hard days, obviously. But what I found was the touchstone was, whose life did I impact today and what difference did I make? And I go, gosh, I feel good about that day. I really did do something.
Yeah. Those the doctors working in the newer style of clinic that was kind of created this new model. Do you think that looks sustainable? Is it sustainable financially? Is it sustainable for the physicians in that model? Is it sustainable from a access for patients? Because if we're extending time with the patient, then we're maybe creating less appointments per day. And so just curious on how that looked when you kind of pulled it apart a little bit.
Yeah, it's a great question. So when I evaluate healthcare systems, and I've worked around the world now for years, I always look at the IHI, basically quadruple aim, which is, are you delivering good quality care? Are you providing access to patients? Are the patients happy? And are you happy? I mean, those are really the four drivers. Certainly in the IORA model, the quality of care we were delivering was second to none. Since you had time with patients, you didn't miss any of the important things that you're supposed to be doing. Right? And it gave us time to get creative about how to do things. As an example, I'll tell you a funny story. We were trying to get the diabetic foot exams better. And what we ended up doing, next to us was a Vietnamese nail salon in the strip mall that we had set up the clinics. And they offered pedicures there. And so we said to all of our seniors with diabetes, they said, you're eligible actually for a free pedicure. Would you like to go? And so we would send the seniors over there, and they would get their foot bath set up and get the whole pedicure started. And one of our nurses would go over and do the diabetic foot exam while they were getting their pedicure. So it was a way of sort of, and so the models were, the quality of care was terrific. Patients loved it. The doctors loved it because they suddenly had time to see patients, and they had a team-based model of care. And they were held accountable for the quality of care they delivered, but not necessarily for sort of the speed of the visit. It didn't matter, how many. And so what we found is that you could actually do a lot of patient care without having to do the in-person appointment. The in-person appointment was, in fact, the legacy of the fee-for-service system, which said you can't bill unless the patient comes in front of you. So people were gaming the system by having patients come in for 6-minute visits and creating all of this disruption and havoc when, in fact, the phone call would have worked. And under the model of care that we had, because we were paid differently, we could actually incentivize this sort of behavior. You didn't need to see patients. And if you saw one patient a day, it was terrific. You had to manage a panel of patients. That was the important thing. What I realized at the end of the day was that I think a lot of the way that we practice medicine today is a consequence of this really, really broken fee-for-service system. And so we have created kind of this almost industrial approach to billing for our professional services, which is number of visits, number of procedures, and the acuity of the procedures. So you've created in the back of people's minds this incentive to see lots of patients, to have them come in regularly, to do as many procedures as you can in as short a time as possible, because you're trying to drive up your so-called productivity. It turns your stomach a little bit because, of course, productivity is not the measure that we should be using. What we should be using is the health of the population. Is the patient doing better? Are their acute healthcare needs or their chronic healthcare needs being met? And I think if we were to sit down with a group of your listeners, if you got a group of 10 or 15 people and said, brainstorm a smarter way of keeping this population healthy and happy and giving them access, the answer would not be 36-minute visits in the morning. They would never build it like that. So the freedom that we had, the reason that it worked at Iora and all of the kind of measures came together was that the federal governments here in the United States had come up with a much smarter way of paying for healthcare, which was called Medicare Advantage. And they allowed the insurance companies to basically pass the risk on to the physician group and said, you're accountable for not only quality of care and all those sorts of things, but you're also accountable for the aggregate cost of care of that population. And so the doctors, smart as they are, said, given that we are responsible for the cost of the stroke that's going to happen in 3 years, if the blood pressure isn't controlled today, it's just much cheaper to over-resource primary care and over-resource prevention and over-resource chronic disease management because I don't want to pay for the stroke and the heart attack down the road. It's very expensive. And people just naturally made that pivot to provide better service. So,
Yeah. I've seen that kind of taken a little bit further, and maybe within the NHS system, which we see in the US, British, where we see the physicians being held responsible for the health of their population. So if the patients aren't hitting blood pressure targets or aren't hitting diabetic targets, then there can be a consequence, right? Whether that be financial or whatever. And yet, it's not you who's helping the patient put food on the plate. It's not you who is, making them take their medication. Fascinating, right? Because we get that other kind of little side concern when we're like, and now we're responsible for what they're going to put in their mouth. That's interesting. Anything about that kind of came out of these newer models?
yeah, very, very important question. So I think when you're coming up with incentives, when you're coming up with goals, people obviously will play to the goals. What I said is ultimately, we do want to see the blood pressure come down. But of course, as you say, there are a lot of variables at work, genetics, patient behavior, honestly, socioeconomic factors. So I think the smarter way to do this is actually to build in process measures. And so I can hold somebody accountable for not getting a hemoglobin A1C. I mean, that's pretty basic. And of course, you don't know where to begin with the diabetic unless you get the A1C. So I think the process measure is something that you should incentivize people to do, which is to say, at least I can do is get an A1C. And there are certain medications that you should be on if your creatinine is whatever, you know, all these things. I can't hold you accountable for not having somebody a blood pressure goal. That's not fair. But I do want to talk about the incentivization because I've had these conversations over the years as a chief medical officer. And what I've come to realize is I don't believe in financial penalties for doctors. To me, it's unfair. People have first of all, are not particularly well paid in primary care and have families to support and mortgages to pay and those sorts of things. And to create that degree of uncertainty to me is just creating stress for people who are otherwise exceedingly well-meaning. I mean, these are highly self-motivated, driven people. What I found is that if you actually, in a completely non-punitive way, collect measures and share them with the doctors, blinded, I don't publicly disclose performances. This isn't like putting your grades up on the wall of a nursery school or grade school. I just share, we collected these measures and we share them privately with the doctors and say, hey, a bunch of your patients didn't have a hemoglobin A1C measured over the past couple of years. And they'll come back to me typically and say, well, that's because there's a good reason for it. Like X, what patient has a fear of needles or whatever it is. In some cases, they're like, oh yeah, So what we ended up doing in the case of Iora was we had health coaches who were attached to the team, and the health coaches felt the responsibility for their panel, and the health coaches just kept on top of stuff and would flag it for the doctors. That's how we got the measures up. It was by facilitating the doctors' instincts to do the right thing, which they have in droves, right?
Yeah. It's fascinating because in the right model, it can make sense and there's a team to support it. And then I'm hearing, well, now they've given us this 15-point checklist that we have to achieve, and it has to be within the appointment that we already have. And there's no extra incentive nor penalty for it, but we must do them. And then if I don't hit such and such on my Press Ganey scores, I don't get my bonus. And if I see a patient by phone, that doesn't count towards my productivity because it doesn't count as an appointment. So now I can't care for my patients by phone, but that doesn't stop the phone calls coming. Like you can see how you take a good idea and then it just gets mashed up.
It does. And of course, everybody's asking for different measures, the insurance companies and this and that. the way that we do this is wrong.
Mm.
The way motivate and incentivize physicians is wrong. And frankly, in the case of the NHS, and I suspect the Canadian system, you're under-resourced. And so there just isn't enough money. If you want to do this well, for example, the A1Cs, you're going to need a health coach or somebody to manage your population health numbers for you in a really, but they don't have the money. They don't want to spend more. So they just dump it on the doctor. Right. And we're wondering why people are burned out.
We in Alberta have this wonderful health council quality. It's the HQCA reports that come out every quarter, and you can monitor your verified panel or the people who've seen you. So it'll be a computer generated panel based on who you've seen in the last year. And it kind of gives you these numbers without consequence. Just like you said, here's some data, have a look at your data with your patients and the people around you, like within your area, and then the people within the province, which is a really wonderful data set, except that if a woman's had a hysterectomy, they cannot remove her from the pap smear
Oh
list.
dear, of course.
So because they can't track what code was used for the hysterectomy, so now she's still within 69, so she still has to have the pap smear. So you're not achieving your goal on the pap smears because half of the people aren't needing one. We can't track that. It's kind of fascinating that it's good because you can like, oh, I could totally get my numbers up for colorectal screening and mammograms, and that's a good project. Let's do that together. We actually like that sort of data.
Mm-hmm.
And then we get frustrated with that, and it's got limitations.
Of course. The data's always buggy, but that's of course why you can't penalize people because it's just not good enough, right? To do this. So
Yeah.
it's hard. I think in the era of AI, actually, we're going to get much better about this stuff because I think the computers are going to churn through the data much more effectively.
Yeah, I think that you're right. The data in it, and good data in could equal good data out. And there is certainly changes afoot for that sort of thing, but the kind of waiting on the human to input that data is the bottleneck for sure.
That's right.
Very good. I've really enjoyed this. This is it's very interesting where you've gone with medicine. It's not the emergency department that you started with, but it's certainly been an adventure, hey?
It has. I mean, I've done, started in EMS. I ended up in emergency medicine. I've been in administration for 12, 15 years. And this year, I'm making what I think is my final career pivot into hospice and palliative medicine. So that will close out my career at the bedside, I think.
Interesting. That sounds like a different pivot. Sounds like you're not too scared of the pivot.
Listen, I've got to go back for training. So I'm doing a fellowship, which I'm really looking forward to. And it's nice. It's going to be nice to be a student again and to be a learner. It's just such a pleasure. I think if I can, what a nice way to spend the tail end of your career, sort of caring for patients in a decompressed way at the bedside. So
Love that. Where can people find you or find your book if they're looking to connect?
Yeah. Well, feel free to reach out. My website is mdmonk.com. And the book is Urgent Calls from Distant Places. And it's pretty much anywhere they sell books, you can find a copy.
Perfect. And then for those who might be feeling burnt out or in that process of should I change, what are some of the things that you might say to them that could help them figure out that idea?
It's an inner journey, right? I think what for me was the most important was getting back to the basics and remembering why when I was a college student and already had not wasted so much time, but really delayed going into medicine and felt the strong passion for going into it. The reasons were good, and I think it required me to go back and remember what those reasons were and why I decided to do it. And it wasn't to be a cog in the wheel. It was really to care for people. It's such a profound and meaningful moment for us. I think sometimes we lose sight of it all because of the broken system. Don't be demoralized. I think the system will be fixed by well-meaning people like us. It will not be fixed by opportunists and greedy people in insurance companies and politicians looking to save a buck. The physicians have got to fix this, and we will. It will take some time, but we will get there. So, but you have to remember the fundamentals, right? The fundamentals are we're here to care for patients in a meaningful way.
Yeah, love that. Anything we didn't talk about that you wanted to?
I don't think so, Sarah. This was just a really lovely conversation.
Yeah, no, thank you very much for your insight, and thanks for taking us kind of behind the other lines about the administrative side of things a little bit. That's fascinating. It's interesting what deep thinkers who've also been in the trenches can kind of think about and come forward with in medicine. So yeah, new models.
Sure.
Yeah, perfect. All right, have a good day, everybody.
Thanks so much, Sarah.
Thank you. Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.